We're going to edit the video.
Yeah, and that's that we just. So, thank you very much for the opportunity to present today to Tech Tokyo. My name is Dr. Ghazanfar Khan. I'm a UK medical doctor and digital health executive who has experience scaling large-scale population health initiatives related to data and tech. And it's a pleasure to be here in Japan to share some of those insights for the Japanese context. I have some slides which we will share with this recording, but just to start off, I will share them. Just bear with me 1 second. So as the slides are just about to load here. Okay. Maybe start that again, actually. So, hello, and thank you very much for the opportunity to present. My name is Dr. Ghazanfar Khan. I'm a physician by training and also digital health executive. Here to share some lessons learned from implementing digital health innovations in large organizations and a few lessons that might be relevant to the Japanese context from my career in global health tech and policy. So the objectives of this meeting, there are 3 key things that I wanted to really share with you. One is to highlight some global case studies across population health and innovation, introduce a simple strategic framework for digital health, scale up, and then contextualize some of those innovation opportunities within the Japanese ecosystem. First, a little bit about me. My career has spanned clinical medicine, global health, policy, and health tech. I've been a physician for 15 years. I then shortly after joined the World Health Organization and was responsible for leading a number of their initiatives related to health systems. I was tasked during the COVID-19 pandemic to build and lead a digital platform to help harness digital health innovations across the world that are relevant to maintaining care. I'll talk a bit more about that in a minute. And my career has then pivoted into health tech, but with a focus on population health. So I led the clinical team for a health tech company, Mendelian, which was using AI software as a medical device to scale and improve the diagnosis of rare disease. We introduced that into the NHS in 2021, and we can talk about that a bit later. Also been involved with Harvard Medical School as a visiting scholar, researching on patient-generated health data, and later as a faculty affiliate on the health tech program. In addition, I've been part of the National Institute of Healthcare and Excellence in an advisory capacity, and also most recently executive director of digital health at Our Future Health, which is the world's largest biobank and health study of its kind, linking genomic and health data. So lots of lessons from lots of different contexts, which I think will be relevant to this discussion. Just a little bit more about me. There's some more information here for offline that we can share. I've also written about patient-generated health data in particular, which is information collected outside the clinic and its use in digital health, which is an interest of mine, and happy to share this article offline. So, really want to get into the sort of the weeds of how you implement digital health innovations within a large organization. And to me, it comes to really a few key principles that have been emphasized to me again and again, whether it's been at the WHO, whether it's been in a national initiative at Our Future Health, whether it's been working in actual startups and in the health tech industry. And I'm actually working both in the East and West Coast at the moment in a fractional advisory position as well, so have insights to share from that. The first is really to align on particular use cases for a digital health intervention very early on. Now, this sounds relatively simple, but you would be surprised by how often organizations will think of a digital health innovation, whether it's building, say, a particular platform, or it's looking at introducing technology into clinical care. But the use cases haven't really been thought through in a real systematic way. And I've often find that aligning on the actual use cases for that technology early on and really interrogating that, having a needs first assessment, really bears fruit when it comes to implementation further down the line. And that involves working with a range of stakeholders. So point number two, these are not just sort of executives, but also clinicians, people in the operational departments, and also, most importantly, patients and the end users. I found where there's been success in large organizations, and I'll share some case studies in a moment, it's been when there's been a confluence of working together with these different stakeholders around the use cases. So identifying one or two priority use cases and then working with those different stakeholders to really co-design as well. The risk is when you do that, however, that you get stuck in a long-winded discussion about principles and policies, and it can be hard to start and get things off the ground. So I'm very much in favor, whether it's been working in a large organization and startup, to have a very sort of a minimum viable product, an MVP-based approach, piloting and iterating, so that you can test fast and learn from what's working and what isn't working. This can be difficult in health because obviously there are a number of ethical data concerns and governance considerations we have to take into account. I have found that though, when you can build trust with those different stakeholders, you can think of sort of key guiding principles early on, what I call like an MVP framework for governance of privacy, sort of guardrails, and that can help support that testing and iteration as well. So, if you're say building a software as a medical device and then trying to implement it in a large organization, really aligning with those stakeholders at a national or regional level, that these are the guardrails we're going to work, and meeting them in person and building that trust and showing what you're trying to do, I think is really important before you start working outside the system without sort of having that buy-in. So aligning on outcomes, working out who your stakeholders are, developing a model for you to iterate on, and then getting going. And like I said, iterating, I think is really important, something that I favor very much in terms of going from idea to the actual product and then scale up. I'll talk through some examples at the moment. And then it's important to really learn from those pilots to scale up and communicate those lessons to those stakeholders. Again, this seems to, having been in lots of different organizations, fairly straightforward, but you'd be surprised by how often one or two of these principles are missing, and often that can lead to problems further down the line. And these are some examples. So often, if there are misaligned incentives, if there's particular silo ways of working between different stakeholders, lack of visibility on the wins, and there aren't any key champions for your work, that can lead to real problems when it comes to implementation. So I can't emphasize this enough. Start with a clear use case when you're working in the health and tech field. Embed those policy and clinical voices in early and make success visible fast. And then scale what works with operational buy-in based on what you've learned. So I'm going to share with you 3 case studies from different contexts. First is the WHO COVID-19 Health Services Learning Hub digital platform, which I designed and led and implemented for the WHO during the pandemic. The aim of this was to bring together key innovations that were going on around the world to maintain care during the pandemic. So as you'll remember, there was a lot being done to fight the virus, but as we sort of progressed during the pandemic, we realized that countries needed to really build up their institutional capacity when it came to care delivery. And what we found during that time was there were lots of digital health innovations that were happening worldwide in lots of different contexts, whether it was high-income countries, low and middle-income countries. And my job was to collate that all and share the learnings between different countries. So that involved working with ministers of health, it involved working with regional small companies that were doing interesting things, giving voice to those innovations and sharing those learnings in a rapid way. So just to pause there. Maybe I can just jump across to these. These are some examples of some of the interventions that we identified. These are, for example, these are in two different contexts. One is a large-scale virtual support intervention for healthcare workers that was undertaken in sub-Saharan Africa. The other was a person-centered virtual visiting service, from what I remember, was in the UK. What we learned during this time was those principles that outlined earlier about aligning on use cases, having stakeholder buy-in and iterating were seen again and again in a global context. It was interesting that the ones that worked really aligned on those principles, either sort of by instinct or by following a sort of specific framework and methodology from previous digital health interventions that had been undertaken. So for the example, in the patient-centered virtual visiting service, this was a service for patients who were isolating, who had COVID, but had ongoing care needs in hospital. What the clinicians had found was that their well-being was much improved when they had a virtual visiting service enabled. So this involved a telemedicine light model being deployed so that patients and family members could see their family members, but also this also helped enable their care because they had information about their care history, which the doctors and nurses didn't have. So these are just two examples of successful interventions that were undertaken during a very difficult time and actually were scaled up from the sort of subnational level with some learnings for the national level as well. Going back to the platform itself, I was building this with a very lean team across a number of different countries. So we had people in Geneva and other parts of Europe who were working with ministers of health and teams from across the world. And again, to me, it became very clear that for this to be a success, we had to align on what the use cases were. And for me, the primary use case was to share learning, particularly from interventions that were going on, not necessarily at the national level, which had sort of use for policy, but also those that were happening, sort of bubbling under the surface at the regional level and below. And the examples I shared were those, because I think that was where the real gold was, so to speak. These were interventions that had been tested in hospitals or in clinics with potential, but they necessarily didn't have the voice to be scaled up yet. So we had a really good role in identifying these types of case studies, making the links both nationally and regionally, so those lessons could be learned and others could help implement them as well. I learned a lot about myself sort of building a platform remotely for UN agency during the pandemic, and so sort of happy to share some of those lessons sort of at a future date. But again, I come back to those points of aligning on a clear use case, building the trust around all the stakeholders, whether it was policy, people who are actually building interventions, internally as well when it came to project management, IT, the web design, making sure we had a clear mission and making sure that we could build something quickly and demonstrate its value. And we did that, which helped enable us to scale it up over the subsequent years. So that's an example from the global context. Something a little bit different. So when I left the WHO, I wanted to really work on the ground, on the front line in the digital health space. And this is about 6 years ago. I joined a health tech company working on rare diseases in the UK, and I led their clinical team for about 2 years. Their focus was on using electronic health record data to improve the diagnosis for rare disease. And the aim was to implement this in the NHS, UK's National Health Service. The tool was a AI software as a medical device using structured data. So this involved scanning essentially the health record for patterns of rare disease to flag patients who may have been missed for a rare disease previously. And this is important because on average, people with a rare disease have a delay in diagnosis of about 6 to 7 years. The idea was, again, to use a tool at a population level to help improve care. And this was aligned with the NHS's priorities on improving rare disease. So just point number one again on use case. The tool was very much aligned with national health policy from the get-go. Having said that, it can be challenging to introduce a new technology into a national healthcare system. We were a small company, but we demonstrated real value, I think, in demonstrating novel pathways for rare disease, working with the NHS, with global pharmaceutical companies, and ourselves as a tech company. We embedded our AI software as a medical device into a number of electronic health records across the country. We worked on building those novel pathways. An example is trying to improve the diagnosis of the care for a rare eye condition that affects children. We used our AI tool to help surface those patients from the health record. We then worked with key opinion leaders who are eye specialists to identify new guidance that we could build to help bring those patients out from the health record context into a pathway that could be suitable for them. And then also worked with a pharmaceutical company who were developing a novel therapy for that eye disease so that the NHS could benefit from patients who might be eligible for life-changing treatment. So you can see this is quite complex. It went beyond just the tech. The tech piece, we sort of had confidence that we could pick patients based on certain characteristics from the health record. The challenging piece was to, one, integrate that into clinical care. Secondly, to also help align those different stakeholders around a common mission. The lessons that I learned from implementing that example, the example I was just talking about on the eye disease, was really about demonstrating a clear win-win across public and private stakeholders. In that example, patients with a rare eye disease would be picked up by a AI tool and plugged into a pathway for potential treatment that could be life-altering for them in a positive way. Clear benefit for the patient in that example. For the NHS, it would align clearly with their national policy on rare disease and improving diagnosis. And for the industry partners that we worked with, it provides patients who could access novel therapies as well. And I found that when aligning and working with those different partners actually was the more challenging component than the building of the algorithms, which I was involved in for surfacing those patients with those eye conditions. So by articulating that clear win-win, it really helped strengthen our case when it came to implementation. The other thing is, when you're working in implementing a tool like this, which is essentially a form of clinical decision support, as a physician myself, working with clinicians and building all of the tools around and support around the actual technology is really important. So in the example I just shared, the tool would flag patients. We would send a report to the patient's doctor and saying, this may be a patient with a rare disease. Why don't you have another look at their record and make a decision? So we weren't making a diagnosis, but we were sort of prompting the clinician to have another look. What I found when it came to implementation was that really working with the clinicians and understanding how to communicate that information to them was crucial to the adoption of the technology. So for example, having the right documents in place for when we flag the patient about explainability around the use of the AI model, how do we make that decision? Also explaining to the clinicians what sort of support they needed, because not all of them were comfortable or understood sort of the nuances of rare disease diagnosis, so educational materials. But also building simple things like referral tools and templates so that we could speed the implementation of the technology and the referral of any patients who may have needed further investigation. So it wasn't just a technology in this example. You can see there was a lot to do with how you implement in a health system, and there's a lot to do about how you make a technology acceptable and improve the utility of it and sort of make the case for it to the clinicians who would be using it. The third example is helping to build a national biobank and longitudinal cohorts for the world's largest population health study in the world. The aim is to have 5 million participants in a national biobank, integrating genomics, lifestyle-linked electronic health record, and survey and clinic data. Aim is to enable new data models that new research that can allow for research into prevention and also research and development for the life sciences industry. My role was to build the clinical trials architecture and also help return information to the participants who'd shared that so they can understand more insights about their health. This was a national initiative, and I was in it for an interim role for a year. Hugely complex because of its visibility at the national level, clearly using a huge amount of data here at a multi-million sort of population level. So there are lots of things to consider here. When it comes to the tech part of it, I think one key lesson really was to start small, to really be participant-led in our approach and the use cases when it came to, for example, the things we want to share with the participants, and also having a very, like I said, a very clear use case when it came to the MVP to scale up approach. That's both for how we returned information to the participants, but also we looked at how we would build a clinical trials platform that would go with it as well. So working with participants from the get-go, having them involved in the journey is really important. Starting small, given the risks here about using large-scale data and a huge population, so we can de-risk the development of the trials platform and the return of health information. But having a clear plan for scale-up, I think those two things are really important in terms of my role in that year. So again, it comes back to those principles: clear use cases, working with lots of stakeholders, putting the participant first in this case, and then iterating and having a plan for scale up. So that's sort of examples from my career, and I hope you found those useful. I want to look ahead a little bit about when it comes to the Japanese context, where can digital health and AI have most impact? I want to start broad initially in terms of some of the big challenges at the moment when it comes to health at a population level. From the World Health Organization, access to health services is a huge area of need. At least 50% of the world's population still lack access to full coverage of essential health services. That might be shocking to many of you. It's often related to lots of different things: physician shortage, there's not enough doctors and healthcare clinicians, poor healthcare infrastructure. Obviously, it often has a sort of social determinants aspect to it, in that marginalized and underrepresented communities are worst affected. And so you can see actually recently that there are lots of interventions, digital health companies in this space around improving health services access, whether it's using large language models as a first point of triage, whether it's clinical decision support tools that can streamline care. This remains a huge area of need and one for us to keep in mind when it comes to future digital health interventions. The second is social determinants. The social determinants of health. One thing I just wanted to make the point of is I wish I'd been shown this slide on my first day of medical school, which is where sort of health expenditure sits and actually the sort of key drivers of health. So on the left, you can see that the key drivers of health are things we control and things we can't. So genetics sort of, we think, account for about 1 in 5, 20% of our overall health outcomes. But really the sort of blue and orange boxes are the key drivers. So socioeconomic and physical environments, our health behaviors, and then our interaction between all those factors. For example, the way we live, the way we work, our education level, the state of our housing, they have much more of an impact on our health outcomes and our access to medical care. And that surprises many people. Altogether, those factors account for about 80% of our health outcomes. However, when it comes to national health expenditures, it's flipped upside down. So in this example, which is a few years old, but the principle sort of broadly still stands, you can see that actually medical services, and this applies to many the healthcare systems across the world, healthcare expenditures are mainly focused on medical services, and very little is actually on those upstream factors that could have an impact on our health outcomes disproportionately more than just spending more on health services. Why do I mention that? Because I think that's a really key area for innovation, where something we don't see when it comes to digital health companies much. Health is much more than just care and care services. I recently did a TED talk on this topic, and happy to share that with this materials for those of you who are interested. But if you think of prevention and population health initiatives further upstream, that could be another area of sort of promise for companies embarking on how they may want to sort of make an impact in health. And again, it's relevant for here in Japan, the non-communicable diseases, which are cardiovascular disease, chronic respiratory diseases, diabetes, account for 70% of global deaths. A huge area of need when it comes to helping improve people's lives. And it remains a UN priority, and Japan is a key leading signatory of this from when the Sustainable Development Goals were launched. So just to summarize those areas, AI-enabled population health initiatives around population risk management, surveillance, prediction could really be important when it comes to addressing some of those areas I mentioned. And then you've got all those other areas around clinical decision support, health assistance. So those are two buckets to think about when it comes to future interventions. Just to finish on the Japanese context for how this all applies, I think, there's clear need here. I'll go back to the use cases. There's a clear, that we have an aging population here in Japan, highest globally, driving demand for preventive and personalized care. That could be a clear use case for digital health innovation, whether it's in a small hospital or in a large organization context. There would be a lot of buy-in for interventions that address this particular need, or the complications and sequelae that come from aging. Universal health coverage is a strong foundation and allows for sort of buy-in again for interventions at the population level related to aging and other non-communicable diseases that I mentioned. And I think there's a real potential here for Japan to be a regional leader when it comes to showcasing how ethical AI and responsible AI could be used for some of these key population health challenges. Because of these factors of the natural demographic sort of burden of disease related to aging, as I mentioned, there is a commitment to universal health coverage. And I think those two factors really help Japan sort of be front and center in terms of sharing any lessons that may come from interventions that could apply to addressing these big population health challenges. So that's all I have to share today. Would be happy to have more of a Q&A in depth on some of those case studies. I want to thank you for the opportunity again to present and wish you all the best. Thank you very much.